Everyone today to QI Power Hour session on how to choose control charts for your data. A special welcome to those of you who are joining us for QI Power Hour for the first time. This is Gary Tier, CEO at the Health Quality Council. QI Power Hour is a free monthly WebEx offering hosted by the Saskatchewan Health Quality Council that provides opportunity for colleagues across healthcare as well as other industries to hear from local and national improvement experts on a variety of quality improvement related topics. A reminder to you that following today's sessions, the session will be recorded and that will be posted on our HQC website, so you can share that out with your colleagues who are unable to join us in person today. We also invite you to check out the recordings and presentations of past sessions on demand at the address listed on your screen. So we're delighted to see QI Power Hour continue to spread. While we're on our website, we also invite you to sign up for the distribution list to ensure that you receive regular invites for upcoming QI Power Hour sessions. So we're trying to make this more efficient and automated, and it's important that you sign up there, and then you'll get all the invites electronically. So now, moving on, we're delighted to see QI Power Hour continue to spread throughout the province, within our healthcare system, as well as with other organizations in Saskatchewan who have an interest in quality improvement. And we've also begun to see spread to other organizations in Canada and even abroad. So again, welcome everyone to QI Power Hour. I'll now pass it over to Chelsea Schwartz, Provincial Improvement Consultant here at HQC, to cover a few of the interactive functions involved in today's webinar. Thanks.
Thanks, Gary. Good morning, everyone. As Gary mentioned, I just want to remind folks of the different ways they can contribute to today's session. Our presenters today have an interactive session planned and encourage your participation on the webinar today. The first feature I want to highlight that you can access is the annotation function by clicking on the pen icon at the top left-hand side of your screen and then selecting the arrow icon. I'm going to give you all a chance to practice this function by indicating where you're joining us from today. Welcome, Travis. Welcome, Dr. Reese. Oh, wow, excellent. So we have some good representation from the province today. Perfect. It looks like everyone's getting the hang of the annotation function. Thanks so much. So the next function that I'd like to highlight is the chat function. So today we're using a bit of a different process. It's called an audio broadcast. So it actually is not possible to speak up on the line today. For some of you, you may be sighing a breath of relief at that. So it is important for us to communicate via the chat function to stay in touch and to do a touch base throughout the presentation to ask any questions that you might have. So as I mentioned, our presenters will also be cueing you to participate in the chat during various parts of the presentation today. So to practice this function, I'll invite you to click the chat bubble at the top right-hand side of your screen. I will ask you to direct your question or your comment to all attendees. So to practice this function, I'll invite you to share the organization that you're joining us from today. Ministry of Health, Water Security Agency, Five Hills Health Region, Prairie North Health Region, RQHR, Alberta Health Services. Great, thanks. Thanks, everyone. It looks like everyone's getting the hang of the chat function as well. We also invite you to tweet out during the session to share your learnings. We will be having some live tweets during the session, so we encourage you to use the hashtag QI Power Hour and the handle HQCSask. And with that, I'm delighted to welcome our guest speakers for today's session, Doug Campbell and Jessica Hamilton. So Jessica Hamilton is a researcher here at HQC since 2011. She previously worked on the Releasing Time to Care evaluation, and more recently she has worked on the Variations and Appropriateness Working Group Project, the Provincial Pathways Project, and the Appropriateness of Care team. In 2015, Jessica completed the Advanced Training Program in Healthcare Delivery Improvement from Intermountain Healthcare in Utah. Most of you will be familiar with Doug Campbell. This is the third presentation that he's given in this mini-series around around measurement. I guess the third this year, 5 overall. He's been with the Health Quality Council since 2014. He's part of the Health System Planning and Reporting team, but is also involved with the ED Weights and Patient Flow Initiative, as well as the Clinical Quality Improvement Program. Like Jessica, Doug is a graduate of the ATP program from Intermountain Healthcare in Utah. So welcome to you both.
Thanks, Chelsea. So we're just passing the host over to me, so it'll just be a second while it comes up on my screen. All right, so today's session is going to build upon what the 2 previous QI Power Hours on variation have taught. Today we're going to be looking at understanding the differences between the types of control charts, how to select the correct type of control chart for your data, and then how to structure that data in Excel to create a control chart. So hopefully you've had a chance to attend or at least review the other QI Power Hours on measurement, because we won't be covering these topics in too much detail today. But in the previous 2 sessions, what we have covered are, in part 1, we looked at what is variation and what types of variation are there. And in part 2, we looked at how do you identify variation and then what strategies do you use to reduce it. So the key takeaways from the sessions were as follows. There are 2 types of variation and 2 ways to identify it. The 2 types of variation are common cause and special cause. Common cause is when you have a process that is stable and it's predictable. Special cause variation is when your process is unstable and unpredictable. We also learned that there was 2 ways to identify variation. You can use run charts, and run charts are helpful for determining how much variation exists. They display data to make process and system performance visible. They show if your changes have resulted in an improvement. They can show if we're holding the gains. They can show if we're starting to slip. And the key thing that run charts can do for you is they show you if your data is random or not random. What a control chart is really an advanced version of a run chart. It's used to distinguish between common cause and special cause variation. So it still shows data over time, it still has a center line, but the thing that's different about it is it has statistically calculated upper and lower control limits. So here's an example of what a control chart looks like. The control limits are the horizontal lines above and below the center lines that are used to judge whether a process is out of control. These are based in the mathematics of probability to help show you when special cause variation is occurring. So webinars on data for improvement can be kind of an interesting thing. Some people absolutely love them, and some people don't love them quite as much. But no matter how you feel about the material, variation is an incredibly important topic in healthcare and in our current system. So if you can learn to understand it and do this well, you'll be leading the way for change in your teams and your organizations. So here's why it's so important. All leaders have difficulty predicting what is going to happen in the future with their performance systems. But using data and control charts, predictions can be made about what the system will look like. Prediction occurs when you can understand if a measure of interest is stable or unstable. Stable measures are predictable. You can anticipate what is coming and manage for it. You can improve through small tests of change like PDCA cycles. But if a measure is unstable, you won't be able to predict what will happen day to day. This would require root cause analysis and possibly process redesign to standardize the process so it is predictable. And once it's predictable, it becomes improvable. So as Edward Deming once said, uncontrolled variation is the enemy of quality. From that, we can infer that understanding and controlling variation are absolutely critical for quality improvement. This helps us to know whether we have an issue and if changes are needed to improve the care that we're providing. So here's an example of variation in the system. Each of these dots represents the time it took for a stroke patient to get a clot-busting drug that they needed. Those special cause data points need to be understood and addressed because they could actually be a life and death situation. A proper control chart lets us identify these cases properly so we can dig into them and understand why they happen so they don't happen again. Here's another example of why variation is important. This graph looks at the number of complaints that occurred on a unit per month. We have an upper control limit at 14 and a lower limit at 0. This system is showing common cause variation. That means that we can expect the data to be anywhere within these control limits on any given month. But something that is common practice in healthcare is to set a goal, and that's a practice that should continue. So let's imagine that we've set a target for this unit of 8 complaints or less per month, so we want to be somewhere in this green area. You'll notice that there are already 3 points that appear to stick out as abnormal. However, we've already established that this is a common cause system, and so we should be expecting points that will be up in this range. Unfortunately, it's very common to react to these points and try and seek out a root cause. This can lead to a lot of work that likely won't go anywhere and may actually tamper with your process. Understanding variation properly would help us avoid situations where we go searching for reasons for special cause that don't exist, because this can be time-consuming and expensive. So here's another example, and it's fairly timely. So about 3 weeks ago, there was an article in the Regina Leader Post about ER wait times slowly improving in Regina. And just to be totally honest, when I was reading the article, I was initially kind of worried they were mistaking common cause variation as special cause. So what I did was dig into it myself, and I went to our ED weights dashboard and pulled off the data. So here's what that data on ED length of stay for RQHR as a region looks like from April 2015 onwards. The control limits have been readjusted twice from baseline because of a persistent change in the data. The rules for knowing when to reevaluate control limits are shared in Part 2 of our QI Power Hour series. So the wait time reported in the story are the ones I've circled in red down here. These points are showing special cause in the desired direction. And this makes sense because I know of all the work RQ is putting into their community networks and their accountable care units. But there's so much data on this chart, I decided to look at it using a different type of control chart. And as Jessica will explain soon, there are other types of control charts you can make depending on how you structure your data. So this is the other control chart I made, which shows the monthly averages and the variation associated with them. Clearly, we can see there is special cause variation in these most recent months. We may also be on the way to showing a shift, which would signify a sustained change in the process. But remember, for a shift to occur, we need 8 points in a row below the mean, and right now we only have 6. So if you give a couple of months, we can reevaluate and see where the control limits might need to be on this graph if we continue to get data points below the mean. So to me, this is why data and variation are so important. It's the foundation of the good news stories that we want to share and celebrate of the good work going on in our province. Using control charts, we can mathematically prove that something has changed for the better, and there's nothing that can be argued about it. It's just the facts. So how do we go about creating control charts? Well, there are some basic steps, and previous QI Power Hours have covered all of these except how to select appropriate charts for analysis.
Great. Thanks, Doug. So we're going to move on to talk about the different control charts and which chart to use when. So something important to consider is that learning to select the correct control chart for your data is an important skill. Each chart has a different formula for computing the limits, and as we've discussed previously, control limits are the hallmark of a control chart, helping us understand what type of variation we have in our system and what we can do about that variation. We having some technical difficulties?
We're offline.
Okay. Sorry, everyone, just having a few technical difficulties. We will get back online.
We're good now.
Okay.
No, it's good.
Okay. So I think you probably could hear me, but I'll just start back at the beginning. So we're talking about the importance of selecting the appropriate chart. Something to consider is that learning to select the correct control chart for your data is an important skill. Each has a different formula for computing the control limits. And as we've discussed previously, control limits are the hallmark of a control chart. They help us understand what type of variation we have in our system and what we can do about that variation. So using an inappropriate chart could result in improper display of your data, which could cause you to make incorrect conclusions and action plans. So as we move forward through the rest of the presentation, we're going to focus on selecting the appropriate control chart given the data that we have. This is the control chart selection guide. It can be found in the Healthcare Data Guide, a reference which we provide for you at the end of the presentation. Chelsea also provided a link to this tool, and we would encourage everyone to try and bring it up on their screen, and you follow along with it in the presentation. And I think she'll put the link, or she's highlighting the link in the chat right now for everyone. So this is an important tool to have at your disposal when you're trying to identify the appropriate chart to use. And you'll see that we return to this a lot throughout the presentation. It's basically a roadmap for what we're going to talk about. One of our goals for the presentation is to help you feel comfortable using this tool in selecting the correct control chart for your own work with your own data. The document helps you understand what type of data you're working with, and from there, what type of control chart to use. The first step as it outlines at the top of the chart, is determining the type of data you have, and that's where we'll start as well. We typically work with two broad types of data. The first is continuous data, which can also be referred to as variable data. Continuous data are quantitative data that use some type of measurement scale. So some examples include time, money, scale data like length, weight, height, or temperature, or throughput, which can be thought of as workload or productivity. Continuous data do not need to be a whole number when they're collected. So we know that something can weigh 45.7 pounds or can be 101.2 centimeters long. Some common examples of continuous data from healthcare include waiting time and length of stay, and examples of workload or productivity include the number of patients admitted or the number of resident days. The other main category of data type that we work with is attributes data. Attributes data are qualitative data that often involve a judgment call as to what something is. So we'll define what an error is, and then we'll consider if something is an error or not. We'll define what late means, and we'll consider if a person is late or not late. In contrast to continuous data, attribute data must be a whole number when they're collected, and there are two subtypes of attributes data, classification data and count data. The type of chart you use differs depending on the type of subtype you have, and so we'll return and talk a bit more in detail about those categories when we're looking at the specific chart. Some examples we often see in healthcare include the number of complications per the number of surgeries in a given month, the number of medication errors per 1,000 doses, readmission rates, the number of falls, and the percentage of patients who smoke. So now we're going to pause for a minute and reflect on what we've just been talking about and do a quiz. So using the annotation tool, please indicate whether the following are examples of attributes data or continuous data. So just a reminder that you can access the annotation function by clicking on the pen icon on the top left-hand side of your screen and then selecting the arrow icon. It might also be handy at this time to look at that chart selection tool to help you with the examples. So the first example are days from screening to home visit. Hopefully you found your annotation tool. If you think this is an example of continuous data, move your tool to the right-hand side of the screen, and if you think it's attributes data, to the left. It looks like we're getting a lot of answers, and I would agree with everyone. This is an example of continuous data. It's quantitative time data. So thanks, everyone, for participating. We'll move on to the next question. So this is the number of employee accidents per 1,000 employee days. If you think it's attributes data, please move to the left and continuous to the right. Good. Looks like everyone's got a handle on this relatively well. This is attributes data. It's qualitative data. We would classify what an accident is and then define whether that employee had an accident or not. Look at one more example. This is the percentage of patients experiencing harm during their care. Great, thanks everyone. This is attributes data, and it looks like everyone has a handle on that. All right, so thanks for your participation. So now that we've talked about the types of data, and hopefully you feel comfortable with the differences between the two, we'll move into the type of charts you use, depending on the data you have, and we'll start with control charts for continuous data. We're coming back, there's one key term that I want to talk about before we look at any specific charts, and this is the term subgroup. So specifically for continuous data, subgroups are a set of measurements obtained under similar conditions. In other words, subgroups are how we organize our data. So in healthcare, we often see data organized as time. We can report it by day, week, or month. Or in healthcare, we'll often see subgroup reported as patients in chronological order. So with continuous data, the subgroup is always the label of your horizontal axis. So an example here, you can see this chart we're looking at sick time for employees. Our subgroup is individual employees, and this is what we plot along the x-axis. In this example, we're looking at the average time to physician initial assessment per month. Our subgroup is months, and that's what's plotted along our x-axis or our horizontal axis. So subgroup properties differ between the various control charts, so that's why I just wanted to spend a little bit of time talking about that. So now we come back to our chart selection tool. We're moving on to the right side of the tool. We've identified that our data are continuous, and we're on to selecting what type of chart to use. So we'll first look at the eye chart, which was one of two charts to use with continuous data. The eye chart, can also be known as the X chart or the XMR chart, is one of the most flexible and useful control charts. It's commonly used when your subgroup size equals 1. So you'll see it often used for data when you have individual patient measurements or when you don't have access to raw data and you only have aggregate information. So in healthcare, examples of where we see eye charts used are with patient-specific clinical measures, lab test data, or we'll often see it with financing data, such as monthly forecasts and budget variances. Something to caution, though, is that because the eye chart is so flexible and easy to use, it's sometimes overused. The eye chart is less sensitive than other charts, and so mistakenly choosing this chart for your data may not give you a true reflection of your system if you should have selected a more appropriate chart. So here's an example of an eye chart in healthcare. This graph shows the time from ED to OR for femur fractures. The x-axis is individual patients, and this is where we can see that our subgroup size is 1. The data plotted is for one individual patient. The y-axis shows the time in minutes. The mean is calculated, and the upper and lower control limits are calculated and plotted as well. In this case, we can see that there's no lower control limit. The graph is annotated, and we can see that there's some special cause following the implementation of a test. So we can imagine a situation where a team could use this data and graph to act accordingly based on the special cause. Recall that in the last presentations, we've discussed how to move forward when you see special cause. So we won't be going into detail about that today, but as Doug has mentioned, those slide decks are available on our website for you to review. That's the eye chart. Next, we'll look at the second type of chart that's commonly used with continuous data, and that's the X-bar S chart. The X-bar and S charts are a powerful pair of control charts. Yes, there are two, and you'll see that shortly when we look at an example. These charts allow you to both learn about the average performance of a system as well as the variation or spread within the data that make up the average. So what does that mean exactly? Well, let's consider the Canadian men's basketball team. They're all relatively tall individuals, and so the average height of that team, we imagine, would be quite tall. Then let's say I join the basketball team. Having one shorter person join the team isn't really going to change the average height that much, but it's the spread of the team that's now going to change. There's greater variation in the individual heights. And that's what the X-bar and S chart is going to help us see. So carrying that thought back over to healthcare, let's consider that it might be useful to learn about the average length of stay per month on a particular medical unit, but it's also useful to understand the variation within that length of stay. Again, it's the X-bar and S chart that will help us do that, and we'll see that shortly with an example. So a few other things about the X-bar and S chart. They require your data to be organized into subgroups. So unlike the eye chart, where your subgroup size could be 1, the subgroup size for an X-bar and S chart needs to be at least 2. X-bar and S charts can handle a lot of large data, and this is really useful in healthcare when we're often working with large administrative data sets. And finally, because the X-bar and S chart is more powerful and gives us a lot of information than an eye chart, it is preferable to use this chart with continuous data if your data allow you to. So now we're going to look at an example of using an X-bar and S chart. In this example, we're looking at radiology lab turnaround time. So first we see the data that we use to create the chart. Along here, vertically, we're looking at the specific number of day, and horizontally up here, we have the number of tests that were done each day. And the individual cells represent the time for that test. So on June 7th, we can see that there were 5 tests done, all with individual test turnaround times. On June 8th, there were 3 tests done, and so forth. We're looking at a 2-week sample. So recall that at the beginning of the presentation, Doug showed us the start of an X-bar and S chart with our QHR's emergency department data. This is how he would have set up that data in order to create the chart. So now we'll look at the X-bar and S chart that we would just generate from that data. The first graph in the pair is the X chart. So on the horizontal axis, or on our x-axis, we have our subgroup, which is days. So recall from our data table, there were multiple times for each day. So the statistic that's plotted is the average of all the tests for the individual day. The mean from the 2-week period is calculated as the center line, and we have our upper and lower control limits calculated and plotted. Then we turn our attention to the S chart. So it's the S chart that plots the variation within the turnaround time of each day. The data that is plotted on the graph is a standard deviation between the turnaround times within each day. And this helps us understand if there's a large amount of spread within each day, which on its own gives us useful information. So in this example, we'll look at June 20th, and we see that there's special cause on that day. The data point is outside the upper control limit. So this indicates that the variation in the process was greater on this day than it was on any other days. Going back up to the X chart, the average on that day appears like any other days, but it's the variation within that period that indicates special cause. So this indicates that there's an unusual spread on the day's sample times. Some were really high, and some were really low. So in this situation, the team would want to investigate the special cause on that day and try to better understand what was going on to have such a wide spread. So these are the 2 types of graphs that are commonly used with continuous data. Remember, we use the I chart when our subgroup size is 1, and the X bar and S chart when our subgroup size is 2 or greater. The X bar and S chart is the more powerful of the 2 charts, so it is preferable to use when your data allow. So now we'll move on to the left side of the chart selection guide and look at the control charts you use when you have attributes data. A reminder that attributes data are qualitative data that often involve a judgment call as to what something is. There are 2 types of attributes data, classification data and count data, and the type of chart you use depends on the subtype that you have. So the first is classification data. This is where your data will be classified into 2 categories. Something either is or it isn't. It conforms or it doesn't. And this would be based upon an agreed-upon definition or criteria that your team are using. With the example on the slide, we're looking at glasses. We define that an error is a glass that has a chip on it, and no error is one that doesn't have a chip. So here we see that the green glass has 1 chip, so we would consider it to be an error. And the white glass, there are no chips, so it's no error. A few other things with classification data. The numerator cannot be larger than the denominator, and we'll often see these data reported as percents. So a few examples from healthcare. So number 1, the number of referrals that were appropriate out of the number of referrals received. So we would have some definition of appropriate. We'd look at a referral and consider whether it was appropriate or not appropriate. And remember, the numerator can never be larger than the denominator. We'd never have more referrals that are appropriate than we would have total referrals. So number 2, the percent of patients who rate themselves very good for satisfaction. Again, our data is either or. A patient is either very good or they are not. And again, the numerator would never be larger than the denominator. We'd never have more patients who rate themselves as very good than we would have total patients who take the survey. So a few other examples include the number of patients who fell each month out of those in our care, and the percent of risk children who were assessed. So that's our classification data, which is one of 2 subgroups of attributes data. Now we consider the other type, which is count data. So with count data, we focus on the number or count of incidents that are non-conforming, such as the number of mistakes, the number of medication errors, or the number of patient complaints. So going back to our glass example, instead of just categorizing the cups into having an error or no error, we count how many errors there are. So we would say the white cup has 0 errors, the green cup has 1 error, and the blue cup has multiple errors. It's important to note that unlike with classification data, with count data, your numerator can be larger than the denominator. Again, a few examples from healthcare would include the number of coding errors and the number of records received. So we could have multiple coding errors within one record. So you could see how the numerator could be larger than the denominator. Other examples would include the number of items missing in referrals to home care out of the total number of referrals, or the number of patient falls each month out of those patients in our care. So we can look at these two types of data further and consider the relationship between classification and count data. So in this example, we're considering errors on medical records. So in this first row, we have 5 records, and the errors are represented by the red X's. Before we begin collecting and classifying our data, we decide that a record fails if it has 1 or more errors. So from a classification perspective, we consider this data. Out of the 5 records, 3 of them have errors, and so we would consider that 3 out of 5, or 60% of our records, fail. Moving down, from a count perspective, we're now interested in the number of errors on each record. So the first record has 2 errors, the second has 0, the third has 8, the fourth has 1, and the fifth has 0. So there are a total of 11 errors over 5 records, or 2.2 errors per record. And so you can see down here in the summary that the numerator is larger than the denominator because there are some records that have multiple errors. So that just further highlights the relationship between classification and count data and shows how you can look at similar data from a different perspective. Now let's pause again. It's a lot of information, and consider what we just went through. We have another quiz to go through to identify count versus classification data. So similar to what we did before, please use your annotation tool to indicate whether the following are examples of count data or classification data. So the first example is the number of infections per 1,000 occupied bed days. Everyone can find their annotation tool again. Good, so I would agree with everyone. This is an example of count data. We are interested in the number of infections. Thanks, everyone. So the next example is the number of errors per 10 admission intake forms sampled each week. Good, it's looking like everyone's generally understanding the difference between the two. Again, this is count data as well. Again, we're interested in the number of errors, not just whether a form had an error or not. And finally, our last example is the percent of patients who die each month. Good. Again, I would agree with everyone. This is classification data. We're interested in whether a patient has died or they haven't died. So thanks, everyone, for participating in that short quiz. So now we'll move on and look at the control charts that you use with attribute data. And again, we're referring back to our chart selection tool. We're on to the left-hand side of the tool, and we'll start with the charts that you use when you have count data. Again, we have to talk about subgroups again, because they're slightly different with attributes data than with continuous data. So the attribute data, the subgroup is the area of opportunity where a defect can occur. So if we think about an example where we're looking at medical errors on a medical record, the medical record is our subgroup. It's our area where the errors will occur. Unlike with continuous data, your subgroup for attributes data isn't necessarily what you plot on the horizontal axis. And with attributes data, another way to think about what your subgroup is to think of what your denominator is. So we have 2 charts that we use with count data. These are the C chart or the U chart. They're very similar. They both display the number of nonconformities, like errors, per your subgroups. But whether to use a C chart or a U chart depends on the type of subgroup you have. If your subgroup size is equal, you would typically use a C chart, whereas if your subgroup size is unequal, you would typically use a U chart. So I think that's best understood if we look through an example. So let's consider a team that wants to improve employee safety at a hospital. So they decide to look at the number of employee needle sticks each month. The subgroup is months because that's the area within which the errors take place. And because the same approximate number of hours was worked each month, our subgroup size is equal, and we would select a C chart to use. Now we'll look at an example of when you'd use a U chart. So consider a hospital that is starting a project to reduce the number of flash sterilizations during surgery. The subgroup is the number of surgeries. That's where our errors take place. And because the number of surgeries varies each week, we would say that our subgroup size is unequal, and we would use a U chart in this situation. So those are the two different charts you use with count data. Just something that we want to touch on quickly is rate data. So in healthcare, we often work with rate data, and we do this when rates of error, harm, or other occurrences are quite small, and they're hard to conceptualize without expressing the number larger as a rate. So we also often do this when we're comparing our data between organizations, so comparing two units or comparing two hospitals or even two provinces. So we'll choose to express our data as a rate, say per 1,000 or per 10,000. So just a common example of this in healthcare would be adverse drug events per 1,000 drugs dispensed. And in this situation, when you're expressing your data as a rate, you want to use a U chart. Okay, so we've made it through most of the chart selection guide. We have one last chart to look at, and that's the P chart. This is the chart that you use with classification data. So a few things about the P charts. P charts display the percent of non-conforming units. So remember, with classification data, your data can be classified into only one of two categories. Something either is or it isn't. An example would be the percent of patients harmed during hospitalization. The patients are either harmed or they're not. With P charts, your subgroup size can be equal or not equal, and unlike with count data, it's impossible for your numerator to be larger than your denominator. So here's an example of a P chart. This one is looking at the percent of 30-month assessments completed. We'd have a definition of what complete is. We'd look at our assessments and consider whether they were complete or not. In this situation, you'll notice that our control limits are not constant. And we know this happens when the subgroup, or the denominator, is unequal. And so we assume then that the number of assessments considered varies each month. So here's an example of another P chart with constant limits. So in this example, we assume that our subgroup or our denominator is equal, and that's why we see constant control limits. So we've wrapped up our tour of the chart selection guide. Just to summarize, there's two main types of data that we looked at: continuous data and attributes data. With continuous data, as you can see here in the first two rows of this table, we have two chart options: the I chart or the X bar and S chart. Which one you use depends a lot on your subgroup size. Remember, the X bar and S chart is more powerful and gives us more information, so it is preferable to use if your data allow. Then we moved on and talked about attributes data and the charts you use with attributes data. As we just looked at, you use the P chart for classification data, and with count data, you use a C chart or a U chart. Which chart of those two you use, again, depends on your subgroup. There are other control charts that you can use in rare event situations or in situations where you might have a lot of zeros in your data, but we aren't getting into those today. So for more information, you can consult the Healthcare Data Guide, which is again referenced at the end of the presentation, or other control chart resources. So finally, again, we've made it through this tool, and our hope is that you have familiarity now with the important concepts, so that you can feel confident using this tool within your own work and with your own data. So now I'll pass it back to Doug.
Thanks, Jessica. So I'm going to do a very quick walkthrough of how to make one of these charts in Microsoft Excel. But just a quick disclaimer, there isn't really a handy Excel formula to do this. So here at HQC and at the Clinical Quality Improvement Program, we're using a program called QI Charts, which is a macro that we can embed into Excel to do this for us. So just for the record, we don't get any reimbursement if you buy any of these software packages. We're just saying what's out there and what's available. So with that in mind, here's how you'd structure the data in Excel to use a control chart program. I'm just going to have to share my screen so you can see what I'm actually doing. So here is what a standard data set tends to look like in healthcare. So this is, along this row here, is the information for one patient. And don't worry, this isn't real data, we just made it up. But it's got information about the date they came for an appointment, who they saw, some of the things about them. And then what we're interested in for our quality improvement project to decrease the number of CTAs that we're ordering because it's considered best practice to actually be doing an angiogram instead. So that's the data that shows up in these columns over here. But what's kind of difficult when you have data in this sort of an orientation is you can't turn it into a control chart properly. So what I want to think about is how I want to structure my data in order to create a control chart. What I would consider doing in this instance is to look at the data per month and say, how many CTAs did I order and how many opportunities did I have? So basically how many patients came in, and I'd want to aggregate the data that way. That's what I've done on this other sheet here. So you can see in April, we had 27 patients come in because we ordered 27 total tests. 15 of those were CTAs and 12 were angiograms. But because our quality improvement project is focusing on reducing CTAs, that's going to be sort of my measure of interest, and I'd want to see that going down. So I'm going to put that into a control chart. So the way I use QI macros is I go up here to this Add-ins button, and then the first thing I like doing is clicking on the chart selection guide. So it pops it up for me, which makes life really easy. So as Jessica was explaining, the first thing you want to do is figure out what type of data you have. So first, is it continuous or is it count? So is it continuous? Is it time? Is it money? Is it scalable or is it throughput? And I would argue that no, it's not. It's kind of a defect, so that puts us over here in counter classification. Sometimes you can make a mistake and say, well, it's sort of throughput, we're throughputting tests and that's what people are taking. But as Sandy Murray kind of explained it to me, is it something you want to write home about? Like, is this what you're trying to achieve? If it's not, because these are defects we're trying to reduce, then it's not throughput. It's not something good, it's a defect, which brings you over to the left-hand side of your chart. Now that I know it's counter classification, I want to think through which side it's on. Because it's either did they get a CTA or did they not, it's going to be classification data because it's in this yes, no, pass, fail category, which leads me to making a P chart. So that's when it gets quite easy. So all I do is click up here on New Control Chart. I select my type of chart as a P chart. For data range, I can select the whole thing. It doesn't matter because I'm going to narrow it down in a little bit. My first row does contain headers, so that's what's in this row here. Although that switched my data range on me, so bear with me. So I'll check that off, and then I can pick where I want the chart to come. So I'm going to click that cell, and that's where it'll appear. Next thing I'll do is click Next, and this is where I start selecting the data that I want. So my index column is what's along my x-axis, and it's going to be the month. My numerator column is the number of CTAs ordered, because that's what I'm focusing on in my project. I want to see that reducing. And I want to know if it's being reduced or not by looking at it within my control limits and using those rules. And then my denominator is going to be the total number of tests ordered, because I want to see that as my base. So I'll click Next. I will use all of the data points to build my control chart because I don't have a large enough sample size yet that I'd want to set them as baseline data and then extend them out. So if you're interested in how you would learn that, it's in our previous QI Power Hours. So I'll click Done. Computer will do some thinking. And bang, there's my P chart. So as you can see, this looks like it's probably common cause variation. There may not be enough runs. We'd have to go through the mathematics of that from the last QI Power Hour. But we do start to see a bit of a shift, but we're not there yet because we only have 5 points under the mean and we're looking for 8. But it looks like we may be on the right track, that hopefully something we started doing is changing this, but we'll have to wait a little bit more to know for sure. So that's how you use the QI charts macro in Excel. It's super easy. Unfortunately, there is a bit of a cost attached to it, but I think it's quite valuable for what you get out of it. So I'm going to stop sharing my screen and go back into the presentation. So that's kind of been our presentation for the day. I'm sorry there's not really a better way of creating these charts other than using the macro or doing a long calculation by hand. But if anyone does know of a free program or is using something else that we could test, please feel free to email me or put it into the chat. But the reason we want to test these programs is just to ensure that they calculate the limits properly. Because if they're free, there's a chance they were just sort of written ad hoc to meet a need, but you'd want to check out all the mathematics to make sure they're working properly. So at the moment, we're kind of thinking that this wraps up the QI Power Hour series on variation, but we are happy to take direction from the group through the poll that will pop up in your browser as you leave the WebEx. So we're interested if there's other things you'd like to know about measurement, please let us know. We're also kind of wondering if there'd be interest in local hands-on sessions where we would come out and work with you and your teams and your data to build control charts and build some local capacity so that you can do this on your own. So also feel free to email myself or Jessica or Chelsea with suggestions on other things you'd like to see in the QI Power Hour or things you want to know about variation. So with that, I believe we'll open it up to questions you have, and thank you again for having us through this measurement series. It's been nice to present it and work through it with you. And pass it to Chelsea to take over from there.
Great, thanks so much, you guys. So we have opened up the chat. I had a few comments that the chat function hadn't been enabled to allow everyone to talk to each other, but that now has been rectified. So if you do have any questions that you'd like to pose to our presenters or to the group, then we welcome you to share that in the chat. I see one question from Monica inquiring about the price for the QI macros.
Sure. I can speak to it briefly, but I think someone will know more than I do in the room. So I know to buy it on a one-off, I believe it was $80 for the QI macros and about $300 for the, or sorry, about $80 for QI charts and about $300 for QI macros. But I feel there's a group deal you can get, but I'm not too knowledgeable on it.
Yeah, so there are licensing options available for QI charts, and you just have to contact the company that makes them to get that. So we could share that information, that contact information for you if you're interested.
Excellent, thank you. So we will welcome questions to continue. In the interim, I just also want to flag our next QI session. So up next for our October QI Power Hour session, we're delighted to welcome Dr. Bryan Robson. For those of you who joined the QI Connect webinar series, you may recognize him as the host of that series. But very interestingly, they'll be sharing Scotland's improvement journey. And why it's interesting for folks here in Saskatchewan is I think that we'll see quite a few parallels in terms of some of the challenges that they experience, some of the learnings that they've had, some of their population similarities and geographic similarities. So he's going to walk us through how Scotland is organizing for quality improvement at scale. And he'll use a framework for high-impact leadership created by the Institute for Healthcare Improvement to reflect on key components that have helped Scotland in its journey to date.
So it looks like we've got a couple questions coming in. I'm still not sure if people can send them to everyone, but they're getting forwarded to us. So there was a question about what program am I using in Excel. So the one I showed was called QI Charts, and that's the run-through I did. But there also is a program called QI Macros, which Henny put in the chat saying it's really easy to use for Mac, and I use it for PC, and it is easy as well. It's just a little more expensive. But QI Charts is the one that I'm using.
Perfect. Thanks, Doug. So with that, I think that we'll end our session. Oh, just check here. So we have an interpretation question. Just going to see if I can open it up here.
So back on the example of errors per chart, doesn't the average potentially misrepresent what's going on? Example, maybe the charts with errors were filled in by the same person, so that it would be more effective to focus on the person. So errors per chart. I guess that would be the question of how you stratify the data. So you'd be looking at count data for the number of errors per chart because you could have more than one. You could then sub-stratify that by errors per chart per person and build your control chart that way if you really wanted to focus in on someone. I might argue that it would be an interesting thing to look at it, but you may not want to share that with your team as while you're doing the improvement. You might want to look at it as a team and try and solve that problem and say, you know what, as a group, we're seeing about 3 errors per chart. How can we build a process better together to make that better, as opposed to saying, hey, Doug, you're making 6 errors per chart and making the rest of us look bad. You'd be able to find that out from the data, but there may be more engaging ways to go about it. But yes, I agree that it could be misleading if everyone's making 0 errors and one's making 6 to show that average, but I think it would be a good way to start that sort of team building aspect of the QI thing instead. Feel free to jump in on that one as well.
Perfect. Well, thanks for sharing your reflections and your questions to date. As Doug mentioned, there's some specific questions embedded within the survey link that will launch at the close of this event. So if you are interested in some of that kind of hands-on support with your local data that was offered today, there's an opportunity to self-identify within the survey. So it looks like we've kind of come to the close of our questions. So I'll invite everyone to join us again for our October session. Just as a reminder, you can sign up for our distribution list as well as register for this session from the HQC website that you see on your screen here. So with that, I'll wish everyone a happy Friday and a great weekend. Thanks, everyone.